Once again here at the Solo 2 and the Only Use Studios, and with Dr. Patino in his office. Another Tuesday, another live broadcast. Please go ahead and comment. Hopefully, we can answer some of your questions on air. We're moving a little bit back toward speaking about general mental health, and today's topic is going to be one that is a term that's used quite often and people experience, and that's depression. But as you've said in the past, Dr. Patino, because we did a show on this a while back, but really didn't delve deep into it, the perception of depression, or when people talk about being depressed, tends to be one about being sad, about being melancholy. But in reality, it's significantly more than that. Is that correct?
Yes, and one of the problems with our nomenclature in psychiatry is that we tend to utilize words that reflect an emotion. Okay, so depression is a lot more than sadness. It's actually a psychological and biological illness, right? So when we talk about are you feeling depressed, people immediately think in terms of sadness, right? Am I sad? And yes, sadness is one of the symptoms associated with depression. But depression as an illness is a syndrome, and it involves a multitude of symptoms, some of which are emotional, some of which are cognitive, meaning how we think, and some of them are biological. Um, so we have to keep that in mind. So when we talk about somebody being sad, the best way to understand it is that you have symptoms like difficulty sleeping or sleeping too much, lack of energy and lack of motivation, lack of interest, inability to enjoy things. You feel very negative about the world and you feel so bad sometimes that you don't think your life has any value, right? And then you have difficulty concentrating, you have difficulty problem solving. Those are cognitive symptoms. That's your brain not functioning well. So it's like everything in your brain kind of slows down and affects a lot of your functions. And we know nowadays that biologically speaking, there's also a lot of inflammatory processes that occur in response to you being depressed because your body perceives your depression as an acute state of stress. Okay, and there are illnesses that get worse when you're depressed. Like if you're diabetic and you get depressed, your blood sugar gets worse.
Hmm.
If you have hypertension, you get depressed, the medications don't work as well. If you have epilepsy and you have depression, you're more likely to have seizures. So there's something that is systemic about depression that we have to keep in mind. The other thing is, if you want to really understand how serious depression is, you need to think about having the flu, or let's say a mild COVID. Now that is fashionable to talk about COVID, think about having lack of energy, lack of motivation. People bother you. You want to be left alone. You don't want to do anything. You don't enjoy anything. You're almost a little irritated when you have the flu, right? Think about having it for 2 weeks nonstop.
Hmm.
And that's when you understand how disabling depression is.
And so, why is it, if we have all experienced it to some extent or another, there's this societal viewpoint of it, and we hear this a lot. Oh, you're depressed. Just get over it, or just be happy, or whatever. And that's distinctly different. That's a moment of sadness or melancholy or whatever versus an actual illness. And why do we have that distinction? Why do people who've never really experienced it on a clinical level are so unempathetic, I guess, for people who do experience it at that level?
I think that it's a two-way street. I don't think we've done a very good job on educating people about the pressures versus sadness, right? So we don't do a very good job on helping people understand that depression is not a weakness of your character. So when somebody tells you just get over it, the message you're getting is you're being weak.
Mm.
You need to be stronger. Only if you're stronger, you won't feel that way. And to some degree, and I see that a lot with kids, when parents are telling their kids, try harder, you know, you need to push yourself a little more. You need to make more of an effort. And what people need to ask is my kid unwilling to make an effort or unable to make an effort, right? Because if you get into an accident and you get a hip injury and you're not able to walk very well, you probably won't be telling your child, just try harder, you know, okay? Because the kid is going to have to rest, he's going to have to do some physical therapy, and he's going to have to regain strength. But when it comes to issues of the mind, when it comes to issues of psychiatry, people tend to automatically judge. So, in part is because of our fear of the unknown, and we humans don't like to hear things that we don't understand, right? We get very defensive about it. So we have this knee jerk reaction to push people away with things that we don't have an answer for, you know? So the projection is you deal with it. You have to try harder. You have to make more of an effort. Just get over it. So we need to, and we've said this in other areas and in our programs, we really need to start talking about listen more and talk less. You know, I was looking at a Facebook meme the other day, and it was reading, God, put your arm around my shoulder and your hand in my mouth, right? so so that's a good message too. I mean, yes, you need to be caring, but don't talk so much, because when we talk so much, we start to express a lot of insecurity, and we need to listen before we talk. That becomes tremendously important. So, rule number one: when somebody tells you, you know, I feel tired, I feel unmotivated, I feel sad, I feel hopeless, I feel helpless, I feel so bad that I don't think my life is worth living, then we have to make sure that we're listening. What is the person trying to tell me versus what do I want to tell that person, right?
Mm. So if I'm just speaking to a buddy, having a bad day, how can I, just as a layman, tell the difference between somebody who's just having an episode of sadness or whatever in their life versus a true clinical depression?
Well, if you're talking to a friend, you're probably going to have more context, right? Because we can't take these symptoms in a picture mode and say this is what is happening to this individual. So part of the diagnosis of depression requires that you look at the movie. How did the patient or how did the individual get to be where they are now, right? So if he tells you, you know, my father died a week ago and I'm feeling very sad, and they may have similar symptoms and depression. There's a very specific reason, right, of why that person is feeling sad. So in that particular situation, like in all psychiatric situations, we need to treasure the fact that the person is telling you, right? So use the fact that somebody is approaching you and telling you, I feel something. It's a great opportunity to listen, okay? Not to problem solve necessarily, especially if you're not trained to problem solve, right? Professionally, like a therapist or a psychiatrist or a psychologist. So the best thing that you can do with a friend is, you know, is to say, I really appreciate that you trust me with this,
Hmm.
right? That will be step number one, because that shows empathy. That shows that you are recognizing that what they're telling you is not an easy thing to say, because they're exposing themselves to you as being weak. And that's why people don't talk about depression, because they don't want to be perceived as being weak. Okay, women tend to be a lot better at this than men are, right? So I lecture often to family doctors, for example, right? And obviously they diagnose more depression than I do, because most people with depression get to see their family doctor before they see me. I see more of the difficult cases. So what happens is that the men showed up at the doctor's office and they say, you know, doc, I'm not sleeping very well. I haven't slept well for the last couple of weeks. You know, I go to sleep, I can't get to sleep, then I fall asleep, and then I wake up three times in the middle of the night. I wake up in the morning feeling really tired, right? I think my testosterone is low, right? But then they won't say, I'm feeling sad. And then you keep looking into it and say, well, I feel fatigued, you know. I'm really not interested. I used to be interested on intercourse and having sex with my wife or my partner, and I'm not anymore. I've lost the interest in things that you used to enjoy. I think my testosterone is low, right? And you keep digging into it. Say, well, is this the first time this happened to you? No, it happened to me 3 years ago. It lasted for about 3 months and then it went away. Okay. And you have to ask them, I mean, do you really feel, do you feel like you have the flu and you've had it for a while and it's not going away? Yes. Yeah. You just don't have a fever, right? So we have to raise the suspicion. I'm not saying that the testosterone is not low. What I'm saying is that we have to add depression to the differential, meaning that we're suspecting that depression might be there because the treatment is going to be different. Okay. So instead of just going away and ordering a testosterone level and take 2 aspirins and call me in the morning or give the patient a medication to help them sleep, let's look at the bigger picture. And then you have to ask, because this is the third leg of the stool that we have to always look at is, what is this doing to you? Is it affecting your marriage? Is it affecting your work? Is it affecting your ability to function and concentrate at work? And the answer is yes, you need to raise a suspicion of depression and have a conversation with the patient about the possibility, but not the possibility of being sad, the possibility of having depression as an illness,
So
right?
really the sadness is the emotional side of it, but then we have to look at the physiological responses as well as the behavioral responses
And
to that.
one of the areas that we don't pay much attention to is the cognitive abilities, meaning your ability to concentrate, your ability to problem solve your ability to listen. So it's not just the moodiness. I mean, most people don't realize depression as an illness is the third leading cause of disability in the world.
Wow.
Okay. After cardiac disease and some other thing. So the number three leading cause of people not able to work is depression.
Wow.
So, and we have discussed this before too. In the United States, we always do the right thing. We always do it for the wrong reason. And in this particular reason, I think that people should be, if they want to be motivated by money, that's fine with me. But get people help, right? We don't want people to be disabled, right? And I can tell because in my practice, I see more severe cases, so I see more disability, right? People who can't get to work in front of a computer and problem solve, they can concentrate, you know, their ability to listen goes down. They get confused at times. So this is a serious disorder that needs to be given the respect it deserves.
And if it's that debilitating, how prevalent is it? I mean, in our society, what percentage of people suffer from clinical depression, but also episodic depression?
Well, most depressions are episodic, even though um, there are different types of depression. We have unipolar depression, we have bipolar depression. But let's talk about unipolar depression, that you only get periods of depression. Most episodes of depression start around the mid to early 20s, right? And they tend to peak around the 30s, right? And most people that I see have had at least a couple of episodes of depression. Sometimes depression becomes chronic.
Mm.
Um, there is no treatment for depression per se. When we talk about treating with antidepressants, we're treating the symptoms associated with depression. But depression requires psychological treatment and requires social treatment, meaning when you have depression, you tend to develop unhealthy ways of coping, right? So let me use diabetes as an example of a chronic illness that requires psychological and social treatment too, right? A lot of people think that you go to the doctor and they give you a prescription for insulin or some medication, metformin, to treat diabetes. Metformin and insulin do not treat diabetes, they treat elevations of blood sugar.
Mm.
The treatment of diabetes is exercise, weight loss, change of habits. Uh, so about 2/3 of the treatment of diabetes has nothing to do with the pills you're taking. It has to do with the choices you make. So the same thing happens in depression because depression as an illness is very sensitive to what happens in your life environment. We are responsive to stress. So if you live in an unhealthy marital situation, if you're having a lot of problems at home, if you're having a lot of problems with having been abused in the past, or if you have problems with drinking excessively, all of that stress prevents your brain from being able to recover fully, right? So you have to learn better ways of coping, okay, with your dysfunctional marriage, with your relationships at home and at work, your social situation, your family history. So all of that requires training. So you can learn how to cope in a more adaptive and less destructive way, right?
And they said that's unipolar depression. So simply a person gets depressed. How often? Once, twice a year? What's the time frame? How many episodes does one have to be to have truly clinical depression?
Well, you can have one episode of depression and have clinical depression.
Hmm.
Now, if let me answer your question backwards. Let's say somebody has first episode depression, and we treat it successfully, right, for a period of 9 to 12 months. At that point, we have to have a discussion with the patient and say, okay, you've done fairly well. You have learned how to cope with life in a less destructive and more adaptive way. You have better skills, your marriage is doing well, your children are doing okay, you have a stable, predictable job, not a lot of uncertainty in your life. So now we can have the conversation about should you stay on the medication or not, because most patients wonder, how long do I have to take this, right? And I always tell patients, if you have had one episode of depression in your lifetime and you successfully treat it and you get taper off your medications, I recommend that you continue seeing someone, whether it's a therapist or a psychiatrist or your family doctor, for a period of at least 18 to 24 months, even if you're not taking medication. That is because the risk of getting a second episode, okay, within the next 5 years is about 50%. So it's fairly high. But there's also a 50% chance you may not get one, right? So if that patient comes back 3 years later and gets a second episode, then I need to treat him again, this time for about a couple of years, and I will have the conversation again. Now, with the understanding, and after you've had a couple of episodes, probably your risk of having a third one is about 80% in 2 years, right? So we have to talk about how much of a risk the patient needs to take, because our job as physicians is not to dictate treatment but provide the patient with options, and one of the options is no treatment, and we have to learn to work with that. We have to learn to work with the idea that patients will not need treatment or may not want the treatment, and we're not going to say you're a bad patient because you don't want my treatment. It's not my treatment, it's their treatment, and we have to offer the other options, the psychological and social options too, because I believe they're as important as the medication. Now, once you have um, consistent episodes of depression, you run the risk of running into something we call treatment resistant depression, you know, because about 30% of patients with severe depressive disorder don't respond to the first antidepressant.
Hmm.
And then only about half of those respond to the second antidepressant. So there's always a population that don't respond well to antidepressants. And that raises a number of questions. One of the main reasons of people not responding to antidepressants is not is that the diagnosis may be wrong. Maybe they have bipolar depression. So we have to spend more time exploring that possibility because the treatment is different. Um, and bipolar depression has different cycles, different manifestations, and they have episodes of mania, which is exactly the opposite of depression. Racing thoughts, irritability, euphoria, no need for sleep, lots of energy, lots of motivation, and lots of risk taking. So when we see that and we diagnose bipolar disorder, we have to switch treatments quite fast. Okay. Treatment resistant depression is a real thing and is not well defined in psychiatric terminology. Uh, but it goes like patients who have received at least one antidepressants from two or three different classes and they have not responded to those, right? So depression may become chronic too. So we have to keep an eye on that. There are newer interventions for treatment resistant depression, and maybe we'll do a program about ketamine in the future or very elaborate pharmacological interventions. TMS, transcranial magnetic stimulation. That's another option. Of course, for most severe, acutely suicidal or psychotic patients with depression, we would use ECT. I don't personally do that. I don't prescribe ECT a lot, but it's an option. It can be useful in certain patients if provided properly.
And that is
Electroconvulsive therapy.
the
So,
old-fashioned shock treatment we've heard about.
yes, shock treatment is still a thing. It's still there, and it's very effective. I've seen it. I mean, I get trained doing ECT, electroconvulsive therapy, but it's basically a technique by which we induce a grand mal seizure, like an epileptic seizure, by giving a shock to the brain. He's had a bad reputation, but in some patients, in particular patients with something we call catatonia, meaning that they just won't move,
Mm.
or patients that have severe psychosis associated with their depression, it can be life saving.
So how should one look at their situation when it comes to depression? A lot of people are very hesitant, as you know, to use medication. They want to simply say, "Oh, it's a psychological issue." What are the percentages and the mixes of someone just does psychological background or treatment, and somebody who just does medical, excuse me, medicinal, or the combination of the two? How does that really work?
Okay. As I said before, most patients with depression, the first stop is not going to be a psychiatrist or a psychologist. It's going to be a family doctor. Unfortunately, in family medicine, they may not spend a lot of time exploring, what is going on with the patient. I usually recommend that if you are suffering from depressive symptoms, either moderate or severe intensity, and after a week or 2 weeks they're not going away, you should seek some help and either uh, talk to a therapist, talk to a psychologist, family doctor if you choose, right? But if you're reluctant to look at medication as the initial approach, try to see someone. Okay, try to see a professional that will do an assessment of you. Now, how do we know if a patient is likely to benefit from therapy or is likely to benefit with medication? It's not a dichotomy, it's not either or, right? But what happens is if your depression is not terribly severe and is not impacting your functioning 100%, right? So let's say you're feeling less motivated, okay? You're sleeping less, but you're still sleeping 6.5 hours. You still have enough energy to go to work, right? Your sex drive has decreased somewhat, but not 100%. So we're looking at intensity of the symptoms that I've described, right? So the next measure that needs to be looked at is what is this doing to my life? If it's not impacting your functionality, you have time to look into therapy, start looking at counseling, trying to look psychological methods like cognitive behavioral therapy, interpersonal therapy that have demonstrated that with moderate depression, mild to moderate depression, can be very effective. So we do know that there is a modification of what happens in your brain by talking to someone and by practicing new ways of coping, right? So we're going to see some people that are going to be able to recover without medications, but it's all intensity and frequency of symptoms. And what is that doing to your life? So a lot of those patients show up in the family doctor, and some of them get started on medications and referred to therapy at the same time. I think that both together are better than either one alone, right? So, but we shouldn't lose sight of the functionality. I'm a very functionality oriented physician because the way I measure improvement is not how low your symptoms are, is what's your life like, right? So, because a lot of patients will take a long time to notice the decrease of their symptoms, right? Invariably, I tell patients, listen carefully to those around you and their opinion on how you're doing, right? People you trust, your mother, your child, your husband, your wife, your partner, whoever it is, listen to what they have to say because they may come back and say, you look a little less tired. You seem to be enjoying things a little more. You seem to be more eager to go to work. You seem to be not as sad as hopeless. You seem to be more future oriented and motivated. But the patient is always the last one to notice it,
Mhm.
right? So we have to hear that. And I always ask my patients, so what are you hearing at home? What did your partner tell you? What your husband or wife told you? Right? Listen to that. Okay, because they're probably better judges of you. You're going to be a severe judge of yourself, right? Because you're going to be trying to find perfection. Okay. The other thing that I think is important to understand is what is the goal of treatment?
Mm.
And the goal of treatment is that you are as miserable as the rest of us who don't have depression. All right. So, because everybody thinks when you sat down in the dumps and you can't move and you have no motivation, not enjoying anything, that everybody else is like eternally happy. And that's not true. And invariably, most of my patients come to see me and say, well, how do you want me to help? And say, well, I want to be happy. So I want to be happy too. Happiness is not a goal, it's a reward. Okay. The goal of treatment of any psychiatric disorder is functional contentment, that you're content with all the miseries attached to life and all the political and social and economic problems we have to deal with on a day-to-day basis. In that process, we had to find contentment, but we had to redefine it. Especially in first world countries like the United States, we feel almost entitled to happiness. It's like, give me happiness. Well, nobody can give you happiness. It's not a thing, right? It's a reward that you get when everything kind of meets in the center and you have moments of happiness,
The
right?
I think we've talked about it before. Is the big dessert? It's the cherry on top.
Correct.
So,
Correct.
if it's as prevalent as it is, and again, there's certain treatments that you do, um, and again, people are still hesitant to look at this. How do you interact with somebody who you know is having depressive thoughts or knows having clinical depression? What's the best way for us as laymen and friends and family, again, to be that reflective surface to tell them how they're doing, but also to give them warnings of maybe how they're doing? Because if correct me if I'm wrong, there's a genetic component associated with depression often.
Absolutely. If you look at families, they runs in families just like depression, attention deficit disorder, anxiety disorders, bipolar disorder. They all have a genetic base, and they also have a temperamental base, which is the clay that you're born with. Um, but it also has a lot of to do with experience. So we look at who's likely to have depression based on their family history and their vulnerabilities. Like, haven't been abused, but haven't been severely neglected, growing up in an alcoholic environment. There's a lot of different things that also play a role, because your brain, your clay, which is the brain that you're born with, gets molded by experience, right? So the experiences that you have are going to have an imprint on how your brain is developing. So we have to keep that in mind. Now, the big paradox, Vince, is that in this age of information, with all the information we have, people choose not to be informed about things that are affecting them, right? And it's not necessarily just a choice, it's that people are preoccupied with other things and they get distracted, right? So let me give you an example. Um, a lot of people in this country will say that psychiatry and treatment of mental illness is a privilege of those that have insurance or they have wealth, right? Because they have access.
Hmm.
And it's not that there's no services for people without the insurance. I mean, there's a lot of safety nets, especially in the United States, that you can utilize, but you had to be informed, right? So minority populations like our Hispanic population, African American population, um, Asian population in particular, because they're very reluctant to access anything that has to do with mental health, they suffer for a long time, and they usually get forced into getting help. So they get the help for the wrong reason. But one of the reasons that people don't look for the information on how to get help is socioeconomical. When people are poor, they're not worried about how they're feeling or if they have energy or no energy. If they have to get up in the morning because they have to pay the rent, they'll get up in the morning. They're not going to do very well, but they're going to do it. So they're so preoccupied and stressed by socioeconomic issues like supporting my family and what we're going to eat tomorrow, right? That they don't have time, concentration, or energy to look at anything. And here's the bad news. The bad news is that if you have clinical depression, like if you have clinical bipolar disorder or schizophrenia or anxiety disorders, is going to shorten your lifespan just from having it, right? You're not gonna live as long if you don't treat it properly. And we know that, right? We know that inflammatory processes and diabetes and hypertension is much more prevalent in this population. So we have to do the right thing for the right reason, and we have to provide more opportunities for people to learn, right? Like we're gonna probably be doing this again in Spanish, so we can get to more people, so people know that there's help, right? And I think that we need to do a better job of guiding people into where to go for it, right?
So where would that be? I'm talking to a friend. They're speaking to me. I'm listening to their melancholy, their behavioral stuff. Maybe I'm clicking into that cognitive issue that they're not thinking quite right. What do I tell them? Who should they go to? Is it their physician? Is it their friend? Is there what else? Is there options for them?
Yeah, I mean the most common place for people to go and to get access fast is with your family doctor, right? But they have to go in with the idea that they understand that there's something not right, that is emotionally, psychologically, and social, and that there is affecting their functioning, and ask for guidance, right? Um, and the whole idea of not wanting to present yourself as being weak is a huge barrier to this,
And there's
right?
cultural issues associated with that, correct?
Oh, absolutely, absolutely. But I think we have gender issues and then we have cultural issues. And in our culture, weakness is like a big no-no for a man, right? I mean, it's just like that is not acceptable. Uh, so people will rather go to the family doctor and say, "I have a headache." I just had the headache for the last 3 years, and it keeps
Mm.
me in bed and not able to sleep. And then we start digging, so finding out that he's having headaches because he's tense, stress, not eating well, and he's got depression, right? So the family doctor is a good screener to start looking at this. And nowadays, most family practices start screening for this, just like they screen for diabetes, just like they screen for Alzheimer's, just like they screen for hypertension. They screen for depression nowadays. So sometimes we need to let the physician guide you a little bit and provide you with options.
And I do know, and I know we haven't discussed this, there are some resources online if you don't feel comfortable going to your doctor for whatever reasons, that you can take some self tests to give yourself some information to say, okay, look, I am maybe going down that road toward clinical depression, or I'm experiencing clinical depression. And
Well,
then you can
absolutely.
make a more educated decision to then go see that physician and walk
Yeah,
yourself.
and I'm very much in favor of people just Googling depression test and go look for it. But do the test, get the results, and go and get help. Because what happens is that you go in and then you want to learn medicine and psychiatry in the internet and you want to
Self
start
treatment.
managing your own treatment, right? So that's why it's very important that people know their limitations. Okay, I mean, people are always telling us that we have to know our limitations as physicians and as specialists, uh, but it's terribly important to know what you don't know.
So, for everybody out there listening, be aware of your own potential symptoms. Those around you, provide information. Go onto those online resources, and if you get the feedback that says maybe I need to do a little more, do reach out to your physician, and don't be afraid to ask for help. I liken it sometimes to a professional athlete. People think how tough these guys are, but really they're very in tune with all their little things so they can perform at the maximum level. So instead of thinking yourself as weak, think yourself as an athlete, a professional athlete. You want to optimize your performance, and the best way to do that is to work on your physical health as well as your mental health.
And don't forget that you're all you have.
Yeah,
You're gonna
absolutely. You're the
you're
only
gonna
you.
yeah
Every morning, every day, every moment of your life.
exactly. You're gonna have you forever. And check us out in Facebook. Go to our site. Send us some questions. We're more than happy to answer them. Thank you
Uh,
very much, Vince.
Wonderful. See you next week.
Hey, thank you. We'll take
Take
care,
care.
man.